extension, and now we're doing lateral flexion. So you're standing on the side of your patient, your thumb is on the ipsilateral side of the spinous process. You laterally flex your patient into you. The spinous process should come into you because of the quadratus lumborum, but in this case it moves away. So you're going, okay, is this type 2 or is this type 4? So then what you do is you rotate your patient into you. And normally what happens is the multifidus muscle on this side starts to rotate the spinous process anteriorly, so you should feel a decrease of pressure on your finger. However, if the spinous process on lateral flexion moves away from your finger and on rotation it comes into your finger, this is classified as a type 4 fixation. Okay, it's because of a multifidus spasm here. Ipsilateral multifidus muscle spasm, and I'm going to have you go onto your tongue. Actually, before you do that, I'm going to have you sit, and then I'll get you in a second. So what we're going to do first is I'm going to show you guys how to adjust using the iliomamillary technique. Okay, the iliomamillary technique is kind of like a cross bilateral, sort of, but not exactly, in the sense that the arm that you're going to be putting onto your contact is going to probably do pretty much the same thing that you usually do when you are doing a cross bilateral. Okay, so in this case, what's happening is there is a type 4 fixation, and one of the mammillary bodies is more posterior. Can you see this? Okay, this mammillary body is more posterior because of this multifidus spasm that's happening right here. So what I'm going to be doing is I'm going to be applying a pisiform contact to this mammillary body. I'm going to be standing contralateral to the side of the lesion, applying a pisiform contact to the mammillary body like I would do if I were higher up on the transverse process, like a cross bilateral, except in a cross bilateral I'm standing ipsilateral to the lesion. Here I'm standing contralateral. Okay, my other hand is going to hook onto my patient's ASIS. And what I'm going to do is I'm going to use this rotational force using the pelvis to torque the pelvis up as I apply this pressure downward like this to thrust. Okay, so the torsion of the hip is going to help me stretch the multifidus muscle. And we can use this as a mobilization where you do small mobilizations, or you can get your sternum over it and thrust. Okay, so Sarah, I'm going to get the paper for you, or you're going to get the paper for you. Okay, so if the spinous process came into your finger, that means that the contralateral side is where the mammillary body is, right? The more posterior mammillary body, right? How do we find the mammillary body? Because we won't actually necessarily feel it. So remember the whole finger business where you cup with the lateral aspect of your index fingers, you're cupping the lateral aspects of the spinous processes, you adduct your fingers as much as possible, your middle fingers will approximate the mammillary bodies. If you want to be precise, you go and you measure your patient's body inches with their fingers in complete adduction. She's a little bit wider than me. Here are mammillary bodies right here. Okay, so I've motion palpated her. It's L3 that we need to find, so we can either count up, or what I usually do is a little bit of static palpation where I challenge the spinous process this way and that way. The idea is if the spinous process is in rotation, then what will happen is when I challenge it from this side, it will be kind of springy because it's already in that direction. But if I challenge it from this way, it'll feel like a hard rock because it doesn't want to move that way. All the rest will feel springy on this side, springy on this side. Okay, here it is. Here's the mammillary body. Take out the skin slack, just like you do for a cross bilateral, except that you're standing on the contralateral side and you are in a fencer stance. Other hand comes and hooks underneath the patient's ASIS. I'm going to be putting my hand underneath your hip. You okay with that? That's what you say to your patient, because otherwise they think you're feeling them up, and that's not good. So, okay, she's going to take a deep breath in and a breath out. On the breath out, what I'm going to be doing is I'm going to be torquing the hip this way. I'm not going to be with my arm, because if I can do it with Sarah because she's smaller, but let's say I had a 400-pound patient, not going to happen. So what I usually do is I usually shift my body weight a little bit to assist me. The shifting will also help because at this point I'm also going to want to shift my sternum over my contact site, which is here, because everybody knows that sternum needs to always go on the contact site in order to push this mammillary body forward, 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 forward. The final thrust will look like a cross bilateral. So it's a one-arm CPR. This hand does nothing. Breath in, all the way up. No. Okay? Do you want to see that?
Yeah, sure.